So here we are again, ready for our postpartum. I could just stick me way over here in a corner and just play it forever. But I don't think I will. I don't think you want to watch me forever. Um, I have to ask Teresa what day of the week it is because we've been so busy. Miss Candler's back from Colorado and she's safe and sound. So you'll be hearing from her today probably. And we are going to go into postpartum. We just finished all the interpartum. We finished the antepartum. So now we're into postpartum. You only have 3 chapters assigned to read. So this should be a fairly easy read for you guys. It's just remembering when what happened. So the questions are going to be questions such that are going to make you critically think. So let's just be sure that we're catching on to stuff, okay? All right, let's get busy. Alrighty then, let's see if I can remember to make this into a slideshow. Come on, computer. Da 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 da. I know you don't want to listen to me sing. I don't even want to listen to me sing. Okay, the postpartum physiological changes is what we'll be talking about first, and then we'll be talking about the nursing care of the family and transition to parenthood. I think I know I made a separate PowerPoint for transition to parenthood because I didn't cover it really in depth. And you'll notice these chapters are not very long. In fact, the longest chapter is the transition to parenthood, which deals more with psyche than it does anything else, and it's very important for the families to integrate together. So we'll spend a little bit of time with that. First of all, you need to know what the postpartum period actually is. Um, it's also sometimes referred to as the fourth trimester of pregnancy. And of course, the postpartum period actually is that interval between the birth of the baby and the time that all those reproductive organs that have been so overused in the last 9 months are going to go back to their normal, hopefully, pre-pregnancy state. Very few things go back to the pre-pregnancy state. Everything that's once been abused during pregnancy usually does not go back to its normal state. But there are a few of them that go back to normal, and we'll talk about those. Usually you'll see this lasting 6 weeks, but it may take a little bit longer depending on the if the patient has any problems or issues that may have caused things to last a little longer. And some people just take a little longer to heal than others. I needed a drink. My mouth was dry. Okay. So first of all, we're going to talk about the uterus. The uterus goes through involution. An involution is just when the uterus is going to go from that humongous size that it was when the fetus was in there to the pre-pregnancy state. And it starts right at the beginning. It starts right after the placenta has been delivered. So we're going to have involution starting at the time that the placenta delivers, and it can take up to 6 weeks to actually get back to total involution. So usually at the end of the third stager, which we remember third stage of labor is the delivery of the placenta. So at the end of the delivery of the placenta, usually you're going to find your uterus midline to the umbilicus and 2 centimeters below. It's going to weigh approximately 1,000 grams. So within 12 hours of delivery, where you normally would think it's going to continue to shrink on down, it's actually going to go up. The fundus is going to rise up above the level of the umbilicus. So you guys need to remember that and be able to recognize that on 12th hour of delivery, that the umbilicus, that the fundus is actually going to rise up to the level of the umbilicus. And this is a normal thing, because usually when it clamps down and it's below the umbilicus, it's usually because we are giving them oxytocin, and endogenous oxytocin is actually higher at the point of delivery for all these things to actually start working. And then it's going to rise back up simply because it's going to take some time for it to actually involute. So about every 24 hours, which is every day, it should descend a little bit more each day, about 1 to 2 centimeters each day. And by the end of the second week post delivery of the placenta, you shouldn't be able to palpate it above the mons pubis. So you should be able to palpate it the whole time they're in the hospital. There should never be a time that you can't palpate the uterus while they're in the hospital. And they will be able to palpate it if you teach them how to make sure that their fundus is firm up until about the end of the second week. And of course, by the end of 6 weeks, as I stated earlier, we should see total involution, total recovery of the uterus back to its pre-pregnancy state. If we have subinvolution, which means the failure of the uterus to return to the pregnant state, most of the time you're going to see the causes of subinvolution to be retained placental fragments and infection. And those two things usually will cause the mother to have postpartum hemorrhage. So if they go home and they've been doing okay, no bleeding whatsoever, and then say 6 days later, all of a sudden they start having heavy bleeding at home, usually it's because of retained placental fragments and infection. So the involution process itself, we've already talked about all that, so we don't have to talk about that again. But by the time you get to the 6 weeks postpartum, it's lost a lot of weight, hadn't it? I wish that could happen to me. I didn't even lose 60 grams when I got my uterus yanked out, so made me sad. So all those new cells that formed are going to remain. As of course, we had to have new cells form as the uterus enlarged, because we had to have material to work with, so we had new cells forming to make the uterus be able to enlarge, and a lot of those new cells are going to remain, and so the uterus is not going to go back to its total pre-pregnancy size. Each progressive pregnancy, each time you get pregnant, the uterus, when it involutes down, will not involute as small as it was the first time. So with the first baby, it will involute down almost to normal. Second baby is going to involute down not quite as much as the first baby, and so forth and so on. You maybe see some women carrying around a larger uterus than what they should have if they had not had babies. All right, afterbirth pains. These are awful. They feel like a really hard contraction. Feels like just like you're in labor all over again. Hemostasis is going to be achieved, of course, by those compressions of the intramyometrial blood vessels. Doesn't happen by clotting. A lot of times, you think of when you have a cut, bleeding stops because you have clotting occurred. But the bleeding stops because of the contraction of the uterus, compression of those little blood vessels that are in the uterus, especially those in that area where the placenta was attached. So you see some bad hemorrhaging happening there if we don't have those contractions to involute the uterus. Oxytocin, of course, the endogenous oxytocin, is released from that posterior pituitary gland. And the posterior pituitary gland is going to deliver the oxytocin are going to cause the oxytocin to be released, and it is going to strengthen and coordinate those contractions. Remember, we talked about endogenous oxytocin is what controls the contractions uh, of the uterus that helps labor, and that's why we augment with oxytocin synthetically to induce labor. It also helps with the letdown of the milk when mom's going to breastfeed, so it actually is a good thing for two different ways, and that's why when mom breastfeeds, a lot of times she's going to have some contractions occurring during and right after she breastfeeds. So it's always a good idea to give them an ibuprofen periodically uh, because they're going to be breastfeeding often. I can't say give it to them every time they breastfeed because you'd overdose them. But if you kind of give them ibuprofen about every 6 hours or so, it'll help with those contractions that they have. Usually the uterine contractions are a lot more painful in women who have had more than one baby because it takes um, more contractions to get the uterus to contract because it's been stretched twice, 3 times. If you've had a large baby and your uterus has enlarged extremely amount, then it's going to take longer and they're going to hurt more because it's going to take a lot harder contractions to get that uterus to clamp down and involute into its pre-pregnancy state. And we just talked about the breastfeeding mom, so we're okay with that. All right, that placenta site can cause us some problems with bleeding if we don't get it clamped down. So we want to be sure that we are checking our bleeding, of course. Placenta, where the placenta was adhered to the uterus, we're going to see vascular constrictions and some thromboses that's going to reduce that placental site. The great thing about the placental site is the way that it heals. That upward growth of the endometrium is going to slough off all your neurotic. I'm neurotic today. I'm very tired. I'm sorry. If I seem to ramble, I apologize. Neurotic tissue, and that's going to prevent scarring. And it's very important that, to prevent scarring, because if we have scarring in the uterus, it's going to cause a problem with implantation of the next placenta for the baby to actually be able to be supported in the uterus. So it's really pretty awesome that this occurs. It also helps to restart your cycles. Once that's healed up, we will begin to restart our menstrual cycle. So, especially the way that it heals, because there's no scar tissue to interfere with that. Also, there will be no pain from scar tissue. A lot of times you have abdominal surgery, you'll have scar tissue in the abdominal area, but the uterus normally will not have any scarring unless there's some type of interventions from the outside, such like if you have a cesarean and you cut into the uterus, you can have scarring where the incision site was at. But the placenta will not leave scarring. Regeneration of the uterus to be able to accommodate placental implantation is not complete until at least 6 weeks after birth. This does not mean that you can't get pregnant and have a baby and be pregnant 6 weeks after birth. It just means that the regeneration is not totally complete. So the regeneration of the inside of the uterine wall isn't complete until at least 6 weeks after birth. What about lochia? What are we talking about with lochia? Lochia is the uterine discharge after birth. Basically what we're talking about, it's the flow. It's the blood flow that we're watching very closely, and we call it lochia. And most of your OB nurses will call it lochia. What's their lochia like? What does it look like? We don't usually say, and some nurses will say how's their bleeding. So basically right at labor and delivery, the only type of lochia you're going to see is rubra, because they usually go home, even C-sections, within 24 to 48 hours. And within that 24 to 48 hours, you're going to usually see rubra. You don't see the serosa start until about 4 days after delivery. Sometimes it's even a little longer, but definitely not. While they're in the hospital, you will not see serosa. And then it'll turn to alba, which is white. And it's kind of just a little bit of a discharge and may last a little bit long, may last for about 2 weeks. So the rubra, let's go back to the rubra. Right after delivery, you may see some clots being passed. And for the first couple of hours, it's moderate to heavy. We really got to keep a close eye on it. And this is when they go into that recovery stage, stage 4. Where we're going to be, the recovery stage usually lasts 2 hours, and this is why, because our rubra is going to, our uterus and our is going to be doing its involuting, and in order for us to make sure that everything is happening the way it should, we have to monitor the lochia and be sure that she's not hemorrhaging. And what we look for is if they saturate more a pad in less than an hour, they are putting out too much blood. They shouldn't be putting out really huge clots. That's not a good thing, but they can pass some clots because as the uterus clamps down and then the placental side is healing and doing the thrombosis, that's where you're going to see the clots forming from, is where usually from that thrombosis. So after the first couple of hours, we should see a decrease in the rubra, and it should like I said, turn into the serosa after 3 to 4 days. And you normally will not see this in a hospital unless you've got a patient who's staying a long time. Now, our C-sections tend to not have very much bleeding. And we give so much oxytocin after delivery to both vaginal and C-section deliveries that we're not seeing the actual rubra lochia that we normally used to see. In a C-section, they suction them out so well, suction and clean the uterus insides fairly well, that we don't see a whole lot of heavy bleeding with them. If we do see heavy bleeding, it's bad. We may see scant bleeding during the first few hours of recovery, and then when we get them up to walk, we may see a whole bunch of blood clots pass, and that would be normal because they haven't been able to put out the blood clots. But you should be making sure your fundus is firm, and sometimes those clots will make the fundus feel firm. So you really have to watch those C-section moms and when you're trying to assess the lochia on those. And that's all the lochia. It's all about the lochia, the lochia. Oh, it's not all about, not the end of it. Here we are at the end. Of course, this is just what I was just saying. The bleeding will increase when they get up and start walking, especially the first time. You may see a clot fall out in the floor. You need to make sure that the patient and the family do not panic over that. It's because they've been in that supine position and it is actually just pooled and clotted. So, when you get worried is when your mom is pale and diaphoretic and her blood pressure is down and her pulse is up and her urine output is down. That's when you get worried. And of course, if the lochia saturates a pad in less than an hour. When a mom is breastfeeding, when they start breastfeeding, that releases that endogenous oxytocin, which is going to cause the uterus to contract more. And that will cause the bleeding to increase because it's pushing the blood that's in the uterus out. Again, the rubra should not continue past that 4 to 5 days. It should be changing to serosa in that by the 4th, 5th day. If we are seeing rubra still continuing in that 4th or 5th day, it's again indicative of possible placental fragments being retained. Because if placental fragments are inside the uterus cannot totally involute. It cannot clamp totally down. It's got something in the way to keep it from actually clamping all the way down. And all your lochia should smell normal. It should smell like a normal menstrual cycle. There should be no foul odor to it. So if you're smelling a foul odor, you need to report that to the physician. It could be a sign of infection, endometrial infection, postpartum infection that women will sometimes contract because of introduction of bacteria. They may not be cleaning themselves well when they go to change their pads. You may have introduced it during labor when you did so many vaginal exams. There's a lot of reasons why they could actually develop infection. So good hand washing, both in labor and during the postpartum period, is very instrumental in preventing infection. All right, we're at your cervix. Every labor delivery nurse likes to wear a t-shirt that says "I'm at your cervix." It's usually really soft after birth. This is one of the reasons I like to tell the parents they don't need to have sex until at least 6 weeks, because that very soft cervix is going to be painful to have sex for one thing, but it's not totally involuted to where it's thick and closed like it used to be before the baby was born. And this allows the introduction of bacteria and anything else to go into the uterus because it's not a closed system at this point. Usually by that second postpartum day, it should reduce down to 2 to 3 centimeters. Should start firming up and start being short. And then eventually it's going to get taller. The external Oz, which is the one that we do the vag exams on and that we did this last weekend, it's never going to regain its pre-pregnancy appearance. It's a little round, beautiful little round, standing up proud cervix before the baby's born. And then after the baby's born, it's kind of sad. It's oblong instead of being round. So, it will never go back to being its pre-pregnancy appearance. Now, we're not going to be going in there and looking at the cervix, by no means, but the doctor will do an exam on the patient at 2 weeks postpartum or 6 weeks postpartum, depending on who your physician is, and determine whether or not the cervix is returning back to its pre-pregnancy state. Usually by the end of 1 week, it's usually still 1 centimeter dilated, so it's still an open system into the uterus. So you should teach the women not to insert anything into the vagina. Some women want to use tampons. I don't know why. You've had a big baby come out of that birth canal. I don't see why you'd want to stick anything back in it, because to me it seems that it would be sore and very painful. But the main reason is because of possible bacteria developing. Can you imagine getting toxic shock syndrome with your uterus being open? I mean, that would be just tremendously septic, and patient would probably be on ventilator if they even survive. If they when you're putting your patient at risk not to be teaching them not to be putting things in there. They don't need to be taking soapy baths. They can soak. Vaginal delivery can actually sit in a warm tub of water and let that warm water soothe the episiotomy or whatever, but they don't need to have soap or anything, because the soap will go up into the uterus. If you don't put anything in the water, then nothing's going to go up the uterus that's not already been in there. And then the vagina itself, it's never going to completely return to the pre-pregnancy state. Before you have a baby, there's rugae all along the line inside of the vaginal vault, so to speak. So, and of course, this increases sexual pleasure for both the men and the women to have those little rugae there. They're very sensitive. But once the baby comes traveling through there, that baby's head acts just like an iron. It just flattens everything out. It's just like you pressed it and hung it up with no wrinkles in it. There will be no longer any rugae in there. So things will be a little different, feel a little different for especially for the guys when you start resuming sexual intercourse. Localized dryness and, of course, colloidal discomfort is very prominent for when you've had a vaginal, especially when you had a vaginal delivery, because of all the possible little lacerations and tears and bruising and generalized soreness throughout, and plus the vagina, the uterus is no longer producing any type of discharge. The hormones have redistributed, and you're not getting a lot of the mucus that you had before, so you may have some dryness going on. So when they do start to have sexual intercourse, we need to teach mom and dad that they should be using a lubricant to help take care of that dryness, because a dry vagina is going to tear when you have introduction of the penis in there. So you really want to make sure that we are keeping the vagina well lubricated. Always use a water-soluble lubricant. Never use a Vaseline-based lubricant. We want a water-soluble that will actually just, once it dries, it'll just absorb and it's gone. Vaseline will kind of just hang out there and hold things in. So we don't want to have a Vaseline-based lubricant. It should always be water-soluble. Usually episiotomies and tears usually will heal without any issues. Now, if you have sexual intercourse before the episiotomy is healed, you may see some tearing there. And you may see the episiotomy get the stitches torn loose. And tears can occur later as well as during the birth. So you really want to make sure that they understand the consequences of having sexual intercourse before the 6 weeks periods are up. You can only visualize that episiotomy when you have the patient lying on her side and have her and raise up her buttocks. Usually you have her raise one cheek, or you raise up one cheek. You have to look at the episiotomy when you are assessing your patient that's had an episiotomy. We don't see as many episiotomies these days as we used to. Doctors are just kind of like letting nature take its course, and sometimes there's some tears, but there's not as many episiotomies done. But once you have sutures placed, you need to be checking the perineum to make sure that there is no visuals. You don't visualize any swelling. The only redness you visualize is just the normal redness of healing, making sure those sutures are intact. Now, these sutures, if the doctor has to suture, these sutures will actually dissolve on their own, so that the patient may see a suture fall out on her tissue. When she goes to the bathroom, she may find one on her tissue or on her pad, and that's perfectly normal. And they should be coming out, within a week to 10 days, she should start seeing those come out. It can take up to 6 months for that perineum to heal. And what that means for mom is her bottom is going to still be sore. It's still going to hurt. And sexual intercourse is not going to feel the best in the world. So we want to try to make sure that she uses her lubricant to try to help not put any more stress on that perineum. That she takes care of her perineum, doesn't sit on her buttocks for a long length of time. If she goes back to work and she has a desk job and she has to sit in a chair, we need her to be getting up, moving around. We need to make sure that she's sitting on something soft and comfortable in order for that perineum not to really hurt, because it's going to take that whole 6 months. And they need to understand that. They need to understand that in 6 weeks, they're not going to be able to hop back out there and everything's going to be normal, because some things just take a longer period of time than others. And of course, at this particular point in time, Kegels are going to be a woman's best friend after childbirth. A lot of times you'll see bladder atony simply because of your muscles have been used up and they're just kind of floppy and stretched out there. And they need to be taught that the Kegels have to be done often, and they have to be done for several days up to a couple of weeks before they'll actually start seeing any results, just like any other type of exercise. It depends on how floppy you are as to how much exercise you need to be able to tote around those good muscles. So they need to understand that it works about the same way. One of the good things about Kegels is that you can do Kegel exercises anywhere without anybody knowing that you're doing them. You can be in a business meeting and giving a professional lecture and still be doing Kegel exercises. So the next time you're watching somebody give a lecture, wonder if they're doing Kegel exercises or do them yourself. It's good for you. All right, let's talk about that endocrine system. Those placental hormones. Once the placenta's gone, we're going to lose all those hormones that it produces. And it's also going to dramatically decrease some of the hormones that we do produce, but we produce in massive amounts when we have the placenta in there. So we're going to see the HC, somatomammotropin, estrogens, cortisol, and insulinase decrease. Of course, once we have that reduction of the insulinase, the main thing you need to keep in mind here and critically think about, what if you have a diabetic mom? So if you have a diabetic mom and you have this reduction of insulinase, it's going to cause a decreased need of insulin in the immediate postpartum diabetic mother. So we really need to be monitoring her blood sugars and giving her her insulin according to her blood sugars and not just a standard amount that she was ordered pre-pregnancy. With a gestational diabetic, usually with the delivery of the placenta, mom's blood sugars go back to normal. They do need to be aware that probably later on in life they will develop type 2 diabetes because gestational diabetes seems to be a precursor to that. That decreased estrogen that we're going to see is going to help our breast enlarge, or actually engorge, not enlarge, and diurese. So it's going to cause breast engorgements and diuresis. We're going to sweat a lot, and our breasts are going to be engorged. So breast engorgement is not a good thing, although it makes women feel like, oh my gosh, my milk is coming in, my breasts are so huge. Well, engorgement's painful. And of course, diuresing, they're going to be sweating a lot. And then we need to tell them that's normal for them to sweat like that. It's not abnormal for them to just break out in a sweat and their whole linens get wet and nasty. So best thing our nursing, showing caring, our number one core value would be to go in there and reassure them that it's normal and change their linens and make them comfortable. Our pituitary hormone and our ovarian function will change. Of course, the posterior pituitary, we've already talked about, is going to produce oxytocin for the letdown of milk. Prolactin levels that are produced by the pituitary gland. The progesterone is going to decrease, and hopefully prolactin levels increase. If we can get that mom to breastfeed immediately after delivery when the when our prolactin levels are high, it will keep those prolactin levels high and help her to be able to produce milk in more quantity and have her milk come in sooner. So it will keep them elevated for the first month, as long as she's continue to breastfeed in a system, quite often. If she decides not to breastfeed, usually the prolactin levels will reach pre-pregnancy range by the 3rd postpartum week. If she is breastfeeding, usually the prolactin levels will stay high as long as she's breastfeeding. So, one thing with breastfeeding, with ovulation, if the mothers are exclusively breastfeeding, it actually provides some type of birth control, although we don't recommend it because most women don't do the exclusive breastfeeding, which means they're up day and night feeding the baby. But that prolactin level is going to delay the return of the of menses, of ovulation, by as much as 4 to 6 months, and that's why it's actually helpful in doing some type of birth control. But we don't recommend it because you can get pregnant. It's not a 99.9% sure thing that you won't get pregnant. It's one of those 75% you probably won't get pregnant. In that non-lactating mother, because those prolactin levels drop, you'll see their return of ovulation in about 4 weeks. So usually their first menstrual cycle is extremely painful, has a lot of clotting to it, and it's a very heavy. It's almost like when they first delivered the baby and their lochia rubra comes out. So you need to forewarn your patients. Your first menstrual cycle will be very painful because it's very scary when you have your first menstrual cycle and it's like the heaviest thing you've ever had in your life, and it's got full of clots and it's very painful. They think that there's something wrong. So you need to be sure and teach your patient that this is a normal process. All right, abdomen. Those of you who have been pregnant probably know this it's probably not a surprise. Your belly still looks pregnant. During those first 2 weeks after you deliver, the abdominal muscles are going to stay relaxed, and it's going to take 6 weeks for them to regain their pre-pregnancy state. And it depends on what your previous tone was. I mean, if you had a belly before you had a baby, you're not going to miraculously lose your belly within so many weeks after the baby's born. It really kind of depends on if you had a good tone before you were good to exercise and you continue to exercise when your doctor allows you to, and how much fatty tissue is there as to how long it's going to take it to get back to its 6 weeks pre-pregnancy state. Sometimes the abdominal wall will separate and it may persist, so they actually see a separation in the abdominal wall where the muscles not used to come together. There's actually a space between them, and it's really kind of interesting to see, but it's very frustrating to the mom because it's actually a body image thing. Our urinary system. Our urinary system gets kind of messed up. We don't really think about the urinary system being part of the reproductive system, and it's not, but it's definitely affected by pregnancy and delivery, and by the hormones that are changing. So when we have those steroid levels that are decreasing because of the postpartum involution period, we're going to be seeing reduced renal function. Our kidney function, as far as being able to filtrate out toxins and be able to keep our electrolytes in balance, blood pressure normal, it usually takes about a month or up to a month for our kidney function to get back to normal. Our kidneys have been really busy for the last 9 months, and they have not only taken care of your waste, but they've taken care of all the waste that came out of the baby as well. So they've been really busy, and you've had fluid overload, you've had all these things going on. So the kidneys have been really busy. And so it takes them about a month to get back to normal. Our ureters and our renal pelvis may take up to 2 months to return to normal because the ureters have been stretched. They've been floppy. Remember we talked about the floppy ureters because the relaxin and hormones and things cause them to get softer and kind of just fold in on each other. And the renal pelvis, of course, are stretched because we have all that all that fluid coming through. So our pelvis actually tend to be able to be stretched out. So it may take up to 2 months for those to return to normal. When the mother delivers, we talked about all that vascular changes that occur, and how the fluid that was once supporting the amniotic fluid and the blood, 400 milliliters of blood in the uterus, all this stuff has gone from out of the system back into the vascular system. So mom is really looking at some fluid overload. So we want to really be sure that we're watching her to make sure she's diuresing that fluid out. So within 12 hours of birth, she should start doing the diuresing. She should be putting out a lot of fluids. She might be putting it out by sweating, but hopefully we're going to see a lot of urine volume. So within that 12 hours of birth, we should be seeing a lot of urine volume. And this diuresing is going to occur because of that decreased estrogen level we just talked about. Removal of that increased venous pressure, of course, in the lower extremities. We no longer have that big old baby and uterus causing increased venous pressure. And then, of course, the loss of all that remaining blood volume. So we got to get rid of all that stuff. And it usually comes out via the kidneys and urine and through sweat. So some of our moms may have incontinence. Either due to the trauma that they may have suffered through birth, it may have caused them to have some uterine atony, or the anesthesia. If we used a pudendal tray, remember we talked about the pudendal block would cause them to lose their ability to void, or to know that they need to void, or the ability to avoid. Sometimes an epidural will work on them that way. So they can actually have some incontinence for up to 3 months. And, their muscles just may not be strong enough. They need to be doing their Kegel exercises to try to help them with the incontinence. But they need to know that it's normal for that to happen for up to 3 months, because it's very discerning for your young moms, especially to have incontinence. It's very embarrassing for them, and they need to know that this possibly can happen. Remember, we talked about if you have an extended bladder, you need to be watching for that, because you can have that excessive postpartum bleeding if that bladder's overextended. Remember, it pushes the uterus up and over to the right. So when you're feeling the fundus to the right and above the umbilicus, you need to be looking at possibly when was the last time you got up and went to the bathroom. Appetite's usually good. They like to eat. Some of them are like, I'm starving, and they have their order placed for when they deliver what they want their significant other to go get them to eat. Some of them want pizza, some of them want Colton steak, some of them want Chinese. It just all depends. But their appetite is usually good. There's very few women who are not really hungry after doing all that exercise of labor and delivery. Y'all know that the peristalsis is slow due to the pregnancy, and it doesn't come back right away. It's not like I had the baby and whoop, there comes the peristalsis. They may not have a bowel movement for several days post-delivery. They're not staying more than 24 48 hours, so we no longer use the criteria you have to have a BM before you go, before we can discharge you. We listen for bowel sounds, we listen to C-sections, make sure they're passing gas before we send them home, but we don't require them to have a bowel movement. Because it's putting mom at, she can't help it. She has decreased peristalsis, and there's no way we can actually make it do better when we're supposed to let it come back naturally. Might also because of dehydration. They work very hard in labor, especially when they're pushing, and they may get dehydrated, especially because we don't let them have anything besides ice chips, and we only run 125 milliliters an hour in their IV, unless, of course, we're doing epidurals or doing intrauterine resuscitation, and they may receive up to 6-7 liters of fluid in a 2-3 hour period. A lot of times when they do need to have a bowel movement, if they've had an episiotomy or had several tears, they're afraid to go to the bathroom because their face is going to hurt. So we need to be sure to keep the pain down on their perineum as much as we can with whatever medications that we need to give them. Such as making sure that we're putting some type of anesthetic, local anesthetic on the, topical anesthetic, on the perineum, on the tears. Use Epifoam or Duraplast or some type of topical anesthesia will work very well for to help with their pain. Sitz baths, ice packs when they first deliver. So it kind of keeps the pain down so they don't really dread it all that much. They will try to resist that urge to go when they don't want to feel the pain of the stool passing over the perineum. And of course, we can give them stool softeners such as Colace to help them not have such a fear of being able to go to the bathroom. High fiber, lots of fluids. We are going to be giving them iron. Most hospitals do. Now, I just found out that Unity no longer gives them anything after delivery. They don't give the prenatal vitamins. They don't give them anything. White River still gives prenatal vitamins plus iron 3 times a day. So, depending on your hospital and the doctor's standard orders, you may or may not be given iron. But if you're given iron, we know that it can cause constipation. And ambulation is also a good thing to help that peristalsis to come back to normal, because the more exercise we get, the more it's going to speed up our metabolism and cause that peristalsis to return. Okay, the breast. These can differentiate between lactating and non-lactating mothers. So we're going to have all those hormones of pregnancy are going to be lowered. And because we have, especially the estrogen being lowered, it's going to stimulate the breast development. So with our breastfeeding moms, we're going to hopefully see colostrum is a yellowish fluid and it's slightly thick, and it will transition to milk within 72 to 96 hours. Now, some of the research that I have done has shown that, further studies of breast milk show that colostrum actually is produced all along. It's just not produced in as large amounts when it switches over to milk. So you won't see it, and it won't really make any difference as far as it goes, but it's not just totally milk. The colostrum is actually still there. Engorgement is going to occur when the infant is not emptying out mom's breast. If my baby is not latched correctly, the milk will not come out as it should, and it's going to back up in the breast and cause engorgement. Some of the things we can do to help with, of course, emptying out the breast and preventing that engorgement is, of course, increase the feedings and be sure the baby is latched correctly. Without that correct latch on, that milk does not come out. It gets stimulated to be produced, but it doesn't come out the nipple. So we want to make sure we have correct latch. We can put warm packs on mom's breast to help hopefully open up those ducts and the milk come out. Have mom pump or hand express the milk out to relieve the engorgement. If the engorgement is so large, and the breasts are so tight, and the nipples can't be compressed, and neither can the breast tissue around the nipple, babies can't latch on very well. So you may have to help them express some milk out in order for the baby to latch on. And tea leaves, tea bags are awesome. They have properties of tea. Has been That's probably why we've always drank tea for way back in the beginning of the day, is because it does have properties that are just awesome. So when you make tea, put your tea bags in the refrigerator and then put these tea bags on sore nipples. Works wonders. Cabbage leaves, cold cabbage leaves, they'll cup the breast because of the way that they're shaped, so that you can put one on each side and wear them until the coolness wears off. And even cabbage leaves have been researched to have some kind of medicinal properties to them that will help with engorgement. So it's not just an old wives' tale. When I first started doing the thing with breastfeeding, I scoffed at cabbage leaves, but now I totally support them. And if you really are like to save money, you can use them to make cabbage rolls after you're through with them. They'll be nice and soft. Our non-breastfeeding moms, we want to make sure, because they are still going to produce milk, they're still going to, that colostrum is still going to, because it's a natural thing for moms to do after they deliver. All the decrease in those hormones are going to cause that breast milk production to increase and the breast to enlarge. So we don't want them to get engorgement, and we can't do the same thing for them that we do for our breastfeeding moms. Our breastfeeding moms, we want them to continue to produce milk, so we do the warm packs and expressing the milk. Non-breastfeeding moms, we don't want to express milk, and we don't want to put warm packs. We want them to wear a snug-fitting sports bra, use cold packs instead of hot packs, and give them Tylenol or ibuprofen for pain. Uh, the best way to prevent them from getting engorgement and mastitis is to bind the breast, and by binding the breast, it will prevent them from producing the prolactin that's going to continue to cause breast enlargement. So those are the differences between lactating and non-lactating. Our cardiovascular system. Remember, we talked about this in labor. Once they deliver and in recovery, things you have to watch for is because that blood volume is going to decrease dramatically. It's going to, actually what it's going to do, it's going to shift. They can tolerate large losses of blood. We talked about that being a safe fail. We'll get it out in a minute. So during vaginal delivery, 300 to 500 mils is what you will normally see blood loss, and up to 1,000 in a cesarean. Now that's a lot of blood loss. Once you get past 500 in a vaginal loss, you're looking at postpartum hemorrhage, and then twice that much, 1,000, is considered normal loss for a cesarean, and that's because it also involves the surgery portion where you lose blood, just cutting into the flesh and having blood loss that way. So they can actually allow them to lose more. There's going to be 3 things that protect mom in that postpartum area that help increase the circulating blood volume. So these 3 things that help increase that circulating blood volume is going to be what helps provide them safety during blood loss. Because, if a normal person lost 1,000 milliliters of blood, we'd be giving them blood. So these are 3 things that are going to help mom be able to tolerate that blood loss. One thing, we eliminate that uteroplacental circulation, and we've already talked about that. At 400 mils, that circulates through that uterus is going to go right back into the vascular system. We're going to lose that placental endocrine function, so we're not going to be seeing where the actual hormones that support the pregnancy are keeping the fluids in spaces like the amniotic fluid and such. So we're going to lose that, which is awesome, because all that's going to go back into the vascular spaces. And then, of course, we're going to mobilize all that extravascular water that's been stored during pregnancy, all those places where we had edema in our legs and our feet and possibly other places. We're going to see all that be mobilized into the vascular system. So that's what helps us with this actual blood loss. And of course, our blood volume is going to be decreasing because we're going to be getting rid of all of the volume, hopefully by diuresing it out. Our cardiac output's going to remain increased for that first 48 hours. It's going to take a while for all of the, as that interstitial fluids move into the vascular spaces, it's going to keep our cardiac output increased for that first 48 hours. Our stroke volume is going to depend on the return of the blood to all the maternal system's venous circulation. And then we also have that rapid decrease in the uterine blood flow, which we've already talked about, and mobilization of the extravascular fluid. This is basically just telling you the same thing that we just talked about, the 3 things that help mom maintain her homeostasis with the blood loss that she suffers during pregnancy. So it may take up to 12 weeks for them to regain their pre-pregnant levels. Now, your job would be to make sure to check their H&H after delivery. And if after, the first postpartum day, if they've gone from a 36 hematocrit down to a 30 hematocrit, you need to teach your mom that she's going to feel tired, and she's going to feel tired maybe for several months. So she needs to nap when she can nap, and try to eat foods that are rich in iron to help build her iron stores up, and possibly take iron supplements. So these are things that you want to critically reason through when you're looking at your postpartum patient. It can take up to 3 months for her fluid volume to become normal and have the actual amount of iron and stuff that she needs in her fluid volume. So our vital signs, we don't see very many alterations unless some abnormality is going to be there, such as we do have postpartum hemorrhage. We see postpartum hemorrhage by the time that we're actually acting on vital signs telling us we've got hypovolemia. Our patient is in critical condition. She has all that excess fluid that has maintained her blood pressure up higher. So we need to be watching for hypovolemia mainly by urinary output, the amount of urinary output, and mom's signs and symptoms. Is she fainty? Is she sweaty? Is she pale? And if she's having very little urinary output, that means that there is a fluid volume deficit in there, and we need to act on it. So don't wait till the vital signs. Don't wait till the blood pressure is so low that it says, we're probably having hypovolemic shock. Oh, our pulse rate is up. We might be having hypovolemic shock. Those things will occur in late hypovolemic shock in a pregnant woman. Usually your hematocrit and your hemoglobin is going to decrease by about 16% at first, and then by week 8 it should be back to normal. So in a couple of months her hematocrit and hemoglobin should be back to normal, which still means she's going to have a lot of fatigue because she's had blood loss. Her white blood cell count is going to remain high for the first 2 weeks, and usually that clotting factor, remember we talked about how the body is going to produce more clotting factors and fibrinogen, and fibrinogen. I can't ever say that right. Anyway, we talked about that and how it increases the risk for venous thrombosis. So we want to be sure, and of course that's just a DVT, what most of us know it. So they're normally increased during pregnancy. So after pregnancy, we have an increased risk for developing DVTs, especially if we do an cesarean, which is an abdominal surgery. We want to be sure that we're getting those CSD hose or TED hose on her right after delivery. Our carpal tunnel that we talked about that may have developed during pregnancy should resolve once we get the swelling from that has caused the compression of that median nerve that caused the carpal tunnel to develop in the first place. Always be very careful when a patient complains of a postpartum headache. If they've had an epidural, it could possibly be a spinal headache. But if they didn't have a epidural, or even if they did have an epidural, we need to monitor their blood pressure. If her blood pressure is high, she could possibly be going into postpartum preeclampsia, even though she didn't have it beforehand. So you want to very careful. If they're complaining of a headache, which a lot of times it's all because of the pushing and things they did, they get intracranial pressure and they develop a headache. But there are headaches, and there are really bad headaches. So you need to evaluate: is it a mild headache? Is it a crippling headache? People who have persistent headaches and their blood pressure are high are very high risk to develop preeclampsia postpartumly, and it does happen. and it's not a pretty thing. And of course, all our musculoskeletal skin and our immune system. Usually, all the things that changed as far as the mother's body pre-pregnancy is going to return to normal within 6 to 8 weeks. We grew a foot size probably, and it's going to stay foot size. Feet don't ever shrink back. They've grown because they needed to be bigger to help support the bigger base of gravity for you. So they're not going to shrink. Too bad. I hate to tell you that. That chloasma that we talked about that's on the face will usually disappear. Doesn't always, but usually. Stretch marks, again, are going to fade, but they never go away. Now, the little spider veins will usually resolve as the blood that, when they popped and the blood caused the spider vein, as that gets reabsorbed into the body, they will actually resolve. Our hair that got so beautiful during pregnancy and full and thick, and we never looked so good in our lives with our hair, is going to start to thin back out because we don't have all those hormones and all that nutrients that we are taking in for the baby. It's going to start to thin out. And we may see, going to be, oh, my hair's falling out, and it just falls out everywhere. When you take a shower, you may actually have clumps that you have to pick up out of the drain. If it falls out to the point of baldness, you probably should talk to your doctor, but it's absolutely normal for it to thin and clumps of it to come out. We don't usually see any significant changes in our immune system. However, we need to be very watchful about what mom needs in the immune system. If she is not rubella immune, she needs to receive a rubella shot after she delivers. We don't give it during pregnancy because it is developed from a live antenated vaccine or virus, so we don't want to give that to mom during pregnancy, but we do want her to have it after pregnancy. We have to be careful when we're giving rubella, because if we have an A negative mom who needs to have a rubella shot, if we give her rubella and she has to have Rogam, the rubella, the Rogam and the rubella will counteract each other, and usually the rubella or the Rogam wins over the rubella, so that it doesn't do her any good to get the rubella shot. So she should have her Rogam and have her rubella shot done in 3 months after she delivers. Pertussis, they can take that during pregnancy. It's not a live vaccine, so they can actually, if they come in their antenatal period and they need haven't had a pertussis vaccine, they need to get that pertussis vaccine. Pertussis has been a really big thing with most, as it's making, whooping cough is making a big comeback, and usually babies get it from their caregivers. So it's really, not only should mom get the pertussis, but everyone in the family should get a pertussis shot if they've not had one. I'm going to stop there because I don't like to have y'all listen to a whole bunch of stuff, so I'm going to stop here. If I can find my little stop button. It's always somewhere different. I thought it was up at the top. It's down at the bottom. So make sure I go back to the right person, right thing. Cam Studio. Alright, we're ready. Push the button.